in my mind, if I was taking care of this patient, the two drugs that I really would have considered would be docetaxel or radium-223. And so I think the decision there comes down to many pragmatic factors. Number one is I can give docetaxel to somebody who's asymptomatic or who's symptomatic. I prefer to give it for metastatic castration-resistant prostate cancer for somebody who is symptomatic. This patient was symptomatic and it would have been reasonable. But the other consideration is radium-223 must be given for a patient who is symptomatic. And when I think about the timing of these agents, it's very clear that if you give radium-223 earlier, it's 6 doses once every 4 weeks, that you're more apt to get all 6 doses into the patient if you give it earlier rather than later in the disease course. And there is some data to show that that has association with better survival outcomes. It's hard to know whether that's driven by those 6 doses, getting them all in, or whether that's driven by just patients having a better prognosis. But it's very clear that those that get all 5 or 6 doses in seem to do better than those who get less doses in. Now, that being said and done, there's a lot of practical considerations. When you give radium-223, you have to get insurance pre-authorization. There are rules in regard to what the absolute neutrophil count should be, hemoglobin count, platelet count. You can't have visceral metastases. And so for those practical reasons, patients' counts are usually better earlier in the disease course. That's because they haven't yet received cytotoxic agents that might cause chronic myelosuppression. And it's also because of the fact that this disease, prostate cancer, can infiltrate the bone marrow. And if it takes up space in the bone marrow, some patients can be chronically myelosuppressed due to disease involvement in the bone marrow. So that's one of the challenges, is for an agent that requires insurance pre-authorization and has clear requirements and limits that you can't have visceral disease, that you have to have certain counts, it makes sense, pragmatic sense, to give it earlier rather than later. Because if I give it later after docetaxel, well, they've already had chemotherapy, it could lead to myelosuppression. Well, the visceral disease tends to develop later in the disease course, and that might prohibit use of radium-223. And, they might have marrow involvement that would lead to, counts being inhibited. There's no data that definitively shows that radium should be given before docetaxel, and that leads to a better survival benefit. But if you live by the theory that my goal is to help my patients live as long as possible with the best quality of life possible, and to use as many of the treatment options as I can that prolong survival, then I have to think about this pragmatically, taking all these considerations into account. And that's why I like the use of radium rather than docetaxel in this patient in that situation. Additionally, the toxicities are low for radium-223. I mean, it can cause some myelosuppression. And since it's degraded and excreted from the body rather than metabolized by the liver or kidney, it can go into the small bowel and can cause some diarrhea. But generally speaking, the side effects and toxicities are also lower than docetaxel. So I totally think that it's very, very reasonable. And in real life practice, I haven't seen significantly more toxicities than what one would see from the randomized phase 3 Alsimca trial that was published back in 2013. There have been some subsequent publications that have shown long-term safety to not be a concern as well either. Some people worry about giving radiopharmaceuticals on long-term risk of developing a leukemia or myelodysplastic syndrome, and we really haven't seen significant challenges with that. So one thing I'd like to emphasize that I mentioned briefly earlier is that it makes a lot of sense when a patient progresses on one line of therapy to not keep pressing down that same pressure point. For instance, if a patient progresses on abiraterone to give enzalutamide, the results are not ideal, and vice versa, abiraterone after enzalutamide. That's because they're all working via that androgen axis. So I mentioned that changing mechanism of action makes a lot of sense. So this is a unique mechanism of action, as radium-223 sits on the same column of the periodic table as calcium. Therefore, if you think about it, calcium incorporates into bone, and prostate cancer, being a bone-predominant disease, causes osteoblastic metastases where there's a lot of bone turnover. Calcium can sit in those areas. Likewise, radium can incorporate into those areas. It basically is an alpha-emitting radiopharmaceutical that has very potent kill. It can induce double-strand DNA breaks in the cancer without a lot of spread, so it doesn't have as much myelosuppression as some of the older radiopharmaceuticals like samarium or strontium. So again, it brings a unique mechanism of action that fits with the biology of prostate cancer.